Okay, I start with Dr. Voon. So, your center runs either the most number of clinical trials or the second largest number of clinical trials in Malaysia. It depends between you and UMMC. Probably overtaken UMMC already. So can you tell us about your experience with the immunotherapy clinical trials? Is there anything we look forward to that's coming to Malaysia?
I mean, nowadays, I would say that for the development of immunotherapy, it started about probably 15 years ago because our pembrolizumab been actually approved about 10 years ago. So usually in drug development, it actually started about, 5 years before. Actually, pembrolizumab itself is a poster boy for clinical trials, oncology clinical trial. It's one of the fastest they've been developed. I mean, from the time of going into first in humans up to actually approval, it only takes 3 years. You still don't see this kind of, across all disciplines, 3 years you can get a drug going. The way they do it is at that time, they actually use seamless trial design. And that design itself is looking into, you go into clinical, first in humans, but that first in human trial eventually have multiple amendment, multiple cohorts, and eventually it actually recruit about 1,000 patients in first in human trials, the phase 1 trials. And subsequently, they go into different cohorts as well in the similar trials, from melanoma, then after that, I would say non-small cell lung cancer. So at that time, this immunotherapy just, started. And at the same time, these are first drugs. One of the first drugs being approved because previously CTLA-4, those things being approved as ipilimumab. That was actually in 2001 at that time. But one of the poster boy I would say that is pembrolizumab because the way they develop is so fast. So along the 10 to 15 years down the line, multiple things we're looking at because we know that we only hit one of the area that is immune checkpoint. But there is different area like I've shown. And like for example, the priming of the immune system against cancer, there's a vaccine. So in terms of vaccine, it's not as robust as immune checkpoint. Because immune checkpoint, at least we have 3 being approved. For example, anti-PD-L1 and the CTLA-4 as well as anti-LAG-3. These are the immune checkpoint molecules. But in terms of priming the cancer vaccine, all those things, then the issue is, we hope that it can be as successful as, immune checkpoint part. But the issue is, I think it's so complex because you're hitting only one part, but there are multiple parts, where these 4 parts. The one, the agonist part, the immune checkpoint part, and the worst is, I think, it's the microenvironment, so complex. So eventually now we're looking at cancer vaccine, and things evolve very fast as well. Like for example, cancer vaccine now is personalized vaccine, so mRNA personalized vaccine. Our team actually are doing another personalized vaccine of receptor non-small cell lung cancer. Meaning if, let's say, the patient have early stage non-small cell lung cancer, they resected it out, then we will actually retrieve the block. And after that, we send it over to, US. It's actually under Moderna. It's a collaboration with MDISD and Moderna. So they're going to personalize, engineer the vaccine against that person, the cancer cells, the antigen cancer cells. Then send back to us, then after we infuse. It's already successful in melanoma. So they're looking back actually into non-small cell lung cancer. I think they're going to go across all tumor types as well. So in that is one of the way, and the other way is do combinations. Instead of just vaccine alone, then you need to actually handle other parts. Like for example, nowadays, more of the vaccine trial will combine with immune checkpoint. So at this immune checkpoint, and hopefully we can get the immune agonist, and at the same time, probably combination. But the problem of combination is actually toxicity, because you are actually pushing the immune system further and further up. And of course, we know that the side effect is being overactivity, just like we're inducing actually autoimmune disease and can get inflamed anywhere. And sometimes the thing that we're looking at as well is potentially, I would say, we're creating cytokine storm as well. Yeah, that is one part. So another part is, in terms of, immune oncology wise, is actually combinations. So besides the CTLA-4 traditionally combined with anti-PD-L1, then we have the other type of combination. Because we have so many receptors that we can interact with and we can actually, I would say, utilize. So now we're looking at combination like anti-LAG-3 together with anti-PD-L1, anti-PD-L1 with anti-TIGITs. And nowadays, the thing is that we are not only looking into 2 drugs infusion, we're actually creating molecules that, the antibodies that have different, I would say, different leg. One arm is getting to one receptor, another arm to another receptor. So we call it bispecific antibodies. But this kind of bispecific antibody as well is not just limited to nowadays it's getting more and more as well. As far as I know, the best of my knowledge, they're creating tri-specific or even penta-specific. But of course, when you create this kind of thing, they may potential problem as well. And at the same time, they're not only creating antibody for anti-PD-L1, they combine it again, and they're actually creating ADC with immuno-oncology together. Meaning that antibody itself is not only inhibiting the receptor of immuno-oncology, but they actually link it to another payload, like the ADC and the drug conjugates, which is actually the sophisticated chemo. Meaning you use chemo together with antibodies together. So it's just like Korean missile, go towards the missile is the chemo itself, it's a payload linked to the antibodies, and after you reach the cancer cell, internalize it and release the bomb, but at the same time also interact with the immune system. So these are things that we're looking at, the combinations part. And of course, now things are moving so fast that we are also into the cells therapy and T-cell engaging. There's another way is because sometimes, it's immune desert or immune excluded. So the T-cell just cannot move into the tumor. But the way to do it is actually combining it, bring the T-cell together to the tumor. It's T-cell engaging therapy. Like for example, BiTEs recently, I think the one that have been approved and going into earlier line of small cell lung cancer is actually tarlatamab. It's a kind of BiTEs, and recently actually the data for the second line came out, beautiful data as well. We involved in that trial as well. And that trial itself, so it's just like, you bring the tumor, the T cell together so that they interact. So, but the issue is you create another side effects, which is actually cytokine releasing syndrome, like we're creating a cytokine storm in the patient. But that part, of course, it can involve neurology as well. Then the ICANS, that is actually, I would say that's something potentially serious. But I would say that there's guidelines and things that we can actually mitigate it. So one thing is that these are something very promising as well. And we're moving even higher is that something that we always behind on hematology is a cell therapy, meaning the CAR T and all those. So for that part as well, it's also immuno-oncology. The CAR T, you engineered it and you infuse back to the patient. Our hematology colleagues has been very advanced in this area, but solid tumor-wise, we're actually behind. But something that is moving very fast in this area, but modifying the CAR T, and hopefully it can be more adaptive as well, and hopefully we can have less side effects. So this is the whole thing that we are looking at. So in a situation that's why driving a car, we cannot just have one part that we are targeting at. At this current point, probably we are targeting one or two parts, but eventually we may use different kind of combination, and at the same time hitting, potentially, hopefully, we can actually have to know which one is driver, and sometimes which one actually is passengers, and potentially we can hit the dominant one, and hopefully we can stop the thing, but at the same time, we have to be very careful with the side effects, because eventually we may actually create a monster that may be killing the horse as well. There's something that I think in drug development we are very, very careful of.
Yeah. Thank you for a very comprehensive answer. Actually, for today, let's say we want to refer you patients, do you have first line or second line trials for lung cancer? Just tell us one or two studies that we can refer you patients for.
We welcome all of you to refer cases to us, but the patient need to fly across the South China Sea or have to swim across the South China Sea. Okay, in Kuching. So one thing is that we actually, like for example, non-small cell lung cancer itself, we have multiple trials actually for first line, and they include actually biosimilar trial as well as, innovative products as well, different kind of combinations. And it depends on what type of subtypes of cancer as well. Let's say EGFR mutant non-small cell lung cancer, then we actually have, second line and third line, post-progression or osimertinib, or possibly first and second line generation is the ADC, mostly of this, and we have a few trials on this area as well. And of course, we also have our KRAS G12C trial just, activated recently. Probably next month we can start recruiting as well. And I think that's one, this include, because the early phase trial across, two different major tumor types. There is the tumor, colorectal as well as non-small cell lung cancer. And of course, there are a few trials coming in as well. And we have potentially a fourth generation EGFR TKI, first in human trials coming in, I think in 2 months' time. And for, if let's say we are about the ALK inhibitors, we actually have, niladakib as well, the fourth generation. The third, ACAZA study, which actually going to start, I think, in about 2 months, probably 2 to 3 months' time. Being selected in the initial part, finishing the startup, and going to start very soon, is against, actually, niladakib against alectinib.
Right. Yep. Okay, so if we want to know the trials referred to in Malaysian Oncology website, there's a clinical trial register that we can find the centers to refer patients to. moving on. So, Ms. Harpreet, so, sorry, okay, yeah, please.
Distinguished panel, I'm Jonathan from CalSys. I'd like to ask a question to the panel, particularly Dr. Voon and Dr. Vijay. I think you've alluded to this just now, that given that EFGR mutated NSCLC remains the most common molecular subtype in Malaysia and frequently presents at advanced stage with osimertinib as the standard first-line therapy, what are the clinicians addressing the inevitable resistance to osimertinib? I think you mentioned the 4th gen. So can you allude a bit more to that? And what are the emerging strategies, whether through next-gen targeted therapies, local ablative techniques, maybe Dr. Vijay can talk a bit more about that, or immunotherapy combinations, like what you're seeing in your clinical trials that promise to extend survival and preserving quality of life for these patients. Thank you so much.
Yeah, thank you for the question. I think it's very interesting. EGF are evolving very, very fast. Even in the first-line setting, we are actually, developing combination besides the next generation EGF TKI. Yeah, we know that. I probably give a very, very brief history about this. First generation, second generation, third generation osimertinib, which has been standard across the world. But the recent 1 or 2 years, then you actually have combination of osimertinib with chemotherapy and also lazertinib plus mariposa with a chemo-free regimen. These two regimens has been developed because we want to improve further in terms for the progression-free survival and hopefully over survivorship as well, against directly head-to-head against osimertinib. This is one of the combination things. And what we see as well in terms of mechanism of resistance, if let's say we use, it depends on what drugs we used before. The mechanism resistance is very different. So if let's say first, second generation, we know that actually T790M, half of them is going to acquire it. Then this can be taken by osimertinib. But if let's say you use osimertinib, then the mechanism of resistance totally change again. And broadly, the mechanism of resistance can be on-target mutations or actually off-target as well. So the on-target one is the EGFR mutation itself, it changed. Like for example, in osimertinib, we're looking at C797S. But for non-on targets, meaning off targets, then you can see like MET amplifications. And of course, sometimes you actually have other pathway being activated, like cell cycle pathway. And the other thing is that, of course, the other thing I think is one of the worst prognosis one actually is the small cell transformation. So it all depends. And at the same time, if let's say use different regimen, the acquired resistance is different. Like for example, if let's say you use mariposa lazertinib is a very strong agents combination, then you may see less like MET amplification being coming up because it's being suppressed by the amivantamab, but different type of thing will come out. So that's why it's very fluid, it's very dynamics. So the thing is that a lot of time we will say that post-progression, we'll do biopsy. It's either liquid biopsy or actually is a tissue biopsy. But the issue both have pros and cons. So one example is, of course, tissue biopsy. There is issue of actually the risk of biopsying the patient and whether the patient ready to be biopsy as well. And number two as well is whether the liquid biopsy is good enough or not. Are we actually missing out the shaders? Meaning those, the tissue one, they actually are not releasing the DNA into the bloodstream, and because our technology is good enough to actually detect the level as well. So these are all the things that we will consider. So probably sometimes we complement each other, we get the biopsy out, but the next big question is, even you do the biopsy, you have drugs or not? Yeah, a lot of time is that you may not have actually targeted. Druggable targets, even you find it. But of course, for us, we like to gather as much information as possible, and especially I think it's extremely important in terms of research as well, that we actually get a biopsy, and I always encourage patients to get a biopsy as well. Because a lot of time we have early phase trial that actually is a basket trials, that they may have different, mutations and all those that we can actually use it. Patient can go into another trials and see whether it's going to help or not the patient in terms of improving the survivorship and all those things. So it's actually an extremely complex thing. The 4th generation wise, I would say that eventually what we see is like ALK as well. The 4th generation and 3rd generation compared to the first 2 generations, you may see less and less on-target mutation. You don't see ALK mutation, but sometimes you may see new combination of mutation come out, the compound mutation, whereby the drugs are not able to handle. Then you need a next generation of more refined molecules that targets a lot of places. The 4th generation, very difficult to define. There are multiple drugs. There are drugs that similar to osimertinib, But actually, in terms of the therapeutic window, it's bigger, meaning larger, so they can actually increase the dose to kill off the cancer cell without any toxicity. They spare the wild type of EGFR, but is that truly considered fourth generation? But there is one of the drugs that actually is coming to our show as a Malaysian show in first in human. That is the next few months. That's coming to my team. Actually, is they call it Omni EGFR TKIs, meaning it covers a lot in not only EGFR, but it covers as well potentially HER2 atypical mutation, all those. So this is actually what we look at, and this is because the person who actually designed the drug is a drug designer. They look at these drugs. They look at actually the conformity of the receptors and see how much, because there are a lot of homology between the receptor. Yeah, like for that HER2 exon 20 insertion, EGFR exon 20 insertion, all those things, they're almost similar, the homologically wise, molecularly wise. So they can actually create drugs that actually can inhibit both and all those. So it becomes something that actually, I would say, I'm hoping that drugs is going to be very successful. I think it's extremely promising. They actually released the structure, all those things in ASCR 2025. And at the same time, we were looking forward for the drugs. And one thing is that when they design drugs, they know which part of the drugs actually is causing the side effects. And try and delete that part from that molecules. So it reduces the side effects, it widens the therapeutic windows, and so that you can have higher dose. I can tell you that most time, any drugs can cure off any cancer. But why we don't use the up to that high dose is because toxicity. You kill the horse as well. So that is the reason why I think eventually what we look at the mechanism of resistance essentially varies. Depend on what drug you use, depend on actually which generation, and depend how many times that you use it. Which line you're using it. The things just keep on evolving. That's why we always say that hopefully we get something out from it. But combination EGFR with immunotherapy at this current point is a no-no. The issue is, actually there's a data suggesting you combine immunotherapy with EGFR, you increase the risk of pneumonitis. That's been well established. Even if, let's say, that's why we seldom start immunotherapy first in combination with chemo, even without the knowledge whether EGFR, because we're worried that it's EGFR, because it's the commonest about 50%. Or the incident in Malaysia. So one thing is that let's say we use that kind of combination, then suddenly the result come back in 1 week later, then we'll be in trouble whether should we use EGFR TKI or not, because we're increasing the risk of pneumonitis, inflammation of the lung for this patient. And the worst still is actually immunotherapy is actually the metabolism is very different. The metabolism itself is actually biological endothelial system. And the half-life is extremely long, can be months. That's why you don't know when should you actually start the EGFR TKI. But you already have one drug that I think is very important. That's why I think all these things we have to take into account. What is the development? Stay tuned, a lot of things coming up.
Yeah, just add on Prof. Voon that he talked about the tumor burdens and the profilings. So another thing is we have challenges with the patient itself, the accessibility to the drugs. So of course in our center we try to enroll all of them in the trial if possible, and we have a trial, or we don't have a trial, we have a group. Sometimes we send to our oncologist Prof, and Prof send to us. And second thing, of course, we send to our social welfare. I think now recently CALCIS actually already collaborated our social welfare to ease the burdens of the patients, to actually able to reach out some of the good drugs which they can't actually access from the other centers, because in University Malaya we have a lot of drug can be reached out much earlier compared to the ministries, because we have a certain way how to actually inquire the drugs, and the patient can benefit it much at once. For example, when I was doing my internal medicine specialist training in University Malaya, I already started using elortinib and gefetinib in 2013 and 14, and KKM just using it is 2-3 years ago. So I used osimertinib in 2014 and 15. So that's how the accessibility is much far easier in our center, or even into the private center. So I think most important thing is the financial in Malaysia need to be really, really addressed. We have a lot of drugs, so we have a lot of way to actually help the patient. We send to Zakat, we send to NGOs, and of course with our social welfare. And social welfare try to actually diversify the fundraising. Recently, they also actually signed with the CALCIS. Yeah, thank you.
Yeah, okay.
Thank you. So I saw that there's about 5 minutes left, but I have 2 questions. I'm Kenneth. I'm from Sarawak. I'm a colorectal surgeon. So first question is to Dr. Vijayan. I've come across in the last few years that getting more and more rectal cancers with lung metastasis. And we have actually realized that many of these situations turn out to be dual primaries. So I'd like to know whether do you have any insights and which kind of cases is suitable to be selected to proceed for more targeted biopsies and studies. For Ms. Harpreet, I would like to also ask your opinion in how, in our current status in Malaysia, do you have any ideas or strategies how we can make targeted therapies and immunotherapies more affordable to become first line, and rather than starting conventional chemotherapies as first line? This is in particular to colorectal cancer. Thank you.
I think, yeah, there's a very interesting questions, very practical questions. He is very right. We recently seeing a dual primary, a dual cancer. So if you ask me which lesion biopsy, I like to biopsy everything, okay? But I have no restrictions. But of course, most important when we want to choose the method of biopsy, the safety of the patient is important. Safety comes first. And also the patient tolerability towards the procedure is very important. If the patient is very frail, can't even sustain under the oxygen, currently sitting in the ward, require high oxygen, of course this patient, we try to go as minimal invasive modality, as minimum as CT guided biopsy if the lesion is in the peripheral. Of course these patients can't do much. If they say we can't do anything, of course we do a liquid biopsy. We send for liquid biopsy for lung cancer panel. We have the 100 panels in our Unestimular here, we does that. Or sometimes we don't know where's the primary, we send 100 panels. And if the patient can tolerate and medium high risk, I try to get engaged with the NS to actually to facilitate the procedure. We can do all the procedures in Unestimular here. We can do the peripheral lung lesion, we can do cryobiopsy, we can do TBNA and all those things, or we can do transbronchial biopsy as well. So if the patient's fitter, of course, we bring in earlier. We do under moderate constant sedations. So what we've done is the most very frightened for all the intervention is patient become hypoxic during the procedures. So thanks to COVID, we learned all about the high flow nasal cannula. So all my procedure I do under high flow nasal cannula. Okay, so the patient tolerability throughout the procedure is good. So I don't get anxiety. My assistant don't get anxiety because when start sedation, many patients tend to the oxygen drop 70, 40, 30, then oh, come on, you know. So when you use high flow nasal cannula, the tolerability is much higher. In all the cases I present to you, 95% we use high flow nasal cannula. And we don't much depend on NS because we can do sedation ourselves. And because of the oxygenation is supported, we can do that. And for your thing, recently we diagnosed one patient, lung cancer, I did a real EBUS, and also got gallbladder lesion. We did a CT guided biopsy, gallbladder adenocarcinoma, and lung cancer adenocarcinoma. So it's a dual cancer. So we're going to have MDT. I'm not sure how the oncology is going to treat this. Yeah, Prof, how you treat this?
I'll answer that later on. We have limited time. Yes, Harpreet, yes.
Interesting. I guess the short answer is national health financing. That's the short answer. Unfortunately, we are not there yet. MMA, MPS, and other professional societies have been lobbying the government on pushing for national health financing. However, we did read with some concern that the health minister has another idea on how he wants to do the financing insurance-wise. But going back to your concern, I guess you've already looked at patient access schemes with the pharma companies, and you probably have already exhausted all those avenues. Right now, then the best option is actually through national health financing. We have not come across anyone willing to take up costing, as in to provide the donations or sponsorship for private sector. That's the unfortunate story. Then when it comes to government sector, I believe most of them, what they're doing is trying to get in through the clinical trials. It's a very sad situation, but there's not much being done politically towards national health financing. Yeah. So I don't have a better answer for you, unfortunately. I'm so sorry.
Actually, for the couple of minutes we have, can you explain a bit about the national health financing? Who is financing it?
That's a good question. So initially, I think when the plan came out, the understanding is that the government finances it. However, there was nobody in the government, no department that wanted to take it up. So MOF didn't want it. They tried with EPF didn't want it. Nobody wanted it. So now we are still not sure who's financing it. We don't have that answer yet. But national health financing ideally just means that whether you go and seek a doctor in a private or a government hospital, you basically don't pay anything. It just means that every Malaysian has free healthcare. Right now, we have universal healthcare only in the public sector. We don't have universal healthcare in the private sector. So that's what national health financing is about. It is ensuring that everyone gets universal healthcare without paying through their nose lah.
I see. I got a feeling it's going to be down to us taxpayer again. And then
I believe that is the direction they are going in. However, the professional societies are still pushing what we can in terms of trying to go in the direction where it is. But even if the government is paying for it, they're still going to pass it back to the taxpayer. So, yeah, I don't think they're looking at. I don't think they're looking at direct, like having a tax for healthcare. I don't think that's what they're going to be doing, but we'll have to wait and see because you never know. This week they come up with one policy, next month another policy. Yeah.
Okay. Any burning last question? We have 1 minute actually. Oh yeah, 1 minute. Okay, can I have each panelist give us one statement about the healthcare direction of our country? I see in the Channel News Asia a few days ago about the shortage of junior doctors in Malaysia. Looks like healthcare is not moving in the right direction. Is the right forum to talk about it? Ms. Harpreet?
It is the maybe wrong forum, but the answer is probably yes, Lord, we're not going in the right direction. Because I think there's not enough being done for the workforce, especially those who are now coming into the workforce. Those of us who are maybe probably more senior, we have done well and we are okay because we came into a system that needed us and there was not too many doctors or pharmacists. But I wouldn't say that that's the same situation for the juniors today. However, I would have to say that I respect the Gen Z because they have got a very strong self or sense and they've got a very strong respect for their time. I think everyone would do well to be like them a little bit more. Yeah, but we're not going in the right direction if that's the answer you want. Yeah.
Vijayan?
I think Prof. in a private, he have all the freedom to ask. We are still bound to the government. To be politically correct, I should say no comment.
Yeah, I think I would say that, as I'm in public sector as well. But I think still something very important, I hope that our healthcare is sustainable. I think sustainability is a major issue, not only in Malaysia, but the whole world, globally. It's something that actually is struggling. But people forget that actually healthcare is an investment. It's not just spending money. But if let's say you see immediately into it, people may see that, they think healthcare is expenditure. Ministry of Health anywhere in the world is just spending and spending and spending. But to forget that the productivity and all those, unforeseen, I would say that, people forget about it. That, the thing that return on investment in terms of healthcare, I think every country, including Malaysia, should invest more in healthcare. Eventually, at the end of the day, it make it more sustainable and you actually reap the fruits of a better healthcare for everybody. I think that is the thing that I was looking forward to.
Thank you. Time's up. Please thank our speakers in the usual manner.